We'd like to thank IOA's own Dr. Patrick Arbore for today's presentation, Suicide Prevention, Safety, and Persons at Risk, What We Need to Know. And he will be joined by Mary Balmana, RN. Dr. Arbore is the founder of Friendship Line and is the director of the Center for Elderly Suicide Prevention and Grief-Related Services, both programs at Institute on Aging. He conducts workshops and presents lectures, both locally and nationally, and he's the author of numerous articles and book chapters on a variety of aging-related topics. He's been a senior lecturer at Notre Dame de Namur University in Belmont, California, and an occasional lecturer in the School of Social Welfare at the University of California, Berkeley. He's also an adjunct faculty, or has been, at the Wright Institute. Dr. Arbore is the recipient of several awards, including the 2013 Mental Health and Aging Award, presented by the American Society on Aging, a silver medalist for public service, sponsored by the Jefferson Award Regional Committee, and the 2016 Norma Satin Community Service Innovation Award for his commitment to human rights and community living. And at this juncture, I will turn the program over to him. Thank you, Patrick.
Thank you very much, Catlin, and we always appreciate your expertise in helping people gain access to these programs. And I also just want to welcome everybody who is going to be in this program today. And I am always very humbled, but also just very touched by people's willingness to engage in this particular topic today, which in honor of Suicide Prevention Month, we are putting on, as we do every September. We usually do one large presentation, and then I do many other presentations throughout the month on suicide prevention awareness. And we decided to begin the program today with Mary Balmana, who is one of our trained grief facilitators, and she's also a survivor of the suicide death of her son. And she has been willing on many occasions to share what it means to be a survivor of the suicide death of a loved one. So we thought it would be really very appropriate for her to start. And I really appreciate, Mary, your willingness, because I know this isn't always easy to do. So if you could introduce yourself, and we can continue.
Thank you, Patrick. I'm Mary Balmana. I am an Institute on Aging traumatic grief participant and the mother of Scott, who took his life 5 years ago. I would like to thank Catlin and Dr. Arbore for inviting me to speak today, especially during this month of suicide awareness and prevention. And I will be sharing multiple perspectives I have experienced since I lost Scott to suicide. And I'd like to say thank you to the professional community, to the volunteers, to those of you who are grievers of traumatic loss, and lastly, to those of you who may be depressed and who have had thoughts of suicide. I'd like to introduce you to my son, Scott. He is my second born, a fourth generation San Franciscan, who was a loving, spirited, and sensitive young man. He is a very proud, he was very proud of his mixed Filipino and Irish heritage, and he sported a tattoo of the sun and stars from the Philippine flag, which was superimposed by a Celtic harp. He is, or was, an avid Giants fan. He attended many games, including 3 World Series, and he is loved and missed by many. Family, friends, and casual acquaintances could not help but be charmed by his smile and his ability to connect with others. Scott dedicated his life to health and fitness as a personal trainer. He was a self-taught dancer and could be seen dancing on the Embarcadero, He suffered from depression and anxiety. In the summer of 2014, he disclosed that he was addicted to opiates, particularly OxyContin. It became a roller coaster ride as his disease progressed, in and out of rehab, and a fight to maintain his sobriety. In the end, he was using both heroin and meth as his drugs of choice. 5 years ago, on Wednesday, March 30th, Scott, at the age of 32, took his life. He was resuscitated by first responders and taken to San Francisco General and was placed in the ICU. When I got to the hospital, a social worker was waiting for me, but it would be an agonizing 2 hours before I could meet with a neurologist who would give me an update. When I saw Scott, he was unresponsive on a ventilator. The plan was to meet with the neurology team, and he was being cooled down, and his body would be slowly warmed, and he would be observed to see if there would be any change. The following Monday, which is approximately 5 days after his admission, he was to be retested for brain activity. I have no doubt in my mind that there wasn't anything else that could have been done for him by the compassionate staff that cared for Scott. Early Saturday evening, however, it became clear that he could no longer sustain his life. His blood pressure began to drop, and despite the first-line medical intervention, it would require more intensive and invasive treatment. So the family agreed at that time that no further measures would be taken. The priest was called to administer last rites, and the family gathered to say goodbye. I asked his nurse to remove his airway tube. And at that moment, I heard a knock at the door, and I was met by a very kind young woman who introduced herself as a member of the Donor Network West team. She explained that she had been alerted that Scott was being removed from life support, and that she could now approach me and inform me that Scott was a registered organ donor, and would I consider honoring his last wish. I was caught off guard because I didn't think he'd be a candidate due to his drug abuse, but I said yes, and after a short discussion with the family, we went into a room and they began to interview us with Scott's history. And it was there that I heard the missing details that I had been kept in the dark regarding how serious his addiction had progressed and his undisclosed multiple suicide attempts. It really helped me put some perspective to a situation that I had no control over. My fear of Scott not being a donor was curtailed, and I was reassured that as long as his tests were negative, that he was healthy and he would be he had a good chance of becoming a donor. So I stayed overnight with Scott and I watched the miracle unfold as his nurse and the donor network team and the respiratory therapist prepared him to be a donor. So the following day on Sunday, we said our private goodbyes, and then we were asked to line the halls as the team wheeled him to the operating room. The family went down to the cafeteria where we awaited the news. And then in less than an hour, I was told the retrieval was in progress. And by the time I reached home, I had a text that stated that Scott's 2 kidneys and liver were transplanted into the recipient. So he was a successful donor. And so I think between the care that he received at the General and also the fact that he has given the gift of life to 3 recipients has certainly in the beginning helped me, accept his suicide, but I still continued to have issues with his suicide and loss and the grief that I was experiencing. So I'm going to now talk about the things that I experienced throughout these last 5 years. So one thing that I know from my own experience and listening to others, that suicide is specific to certain feelings. And some of the feelings are overwhelming feelings of shame and guilt and responsibility. And suicide comes with a feeling of being alone and isolation. And for me, it was because of the shame and the guilt. It certainly is a membership in a club that no one wants to belong to. I began to obsess over why did it happen? You know, did I need to think about who do I tell? Do I not tell certain people? I had extreme anger that was directed towards myself, institutions, like, you know, the fact that Scott didn't have private health insurance and that the mental health system didn't support someone like Scott. I kept thinking, you know, for all the times that he had to go to receive care at the clinic that he would go to, there were multiple clinics, there was always a new practitioner, and he had to tell his story from the beginning. And I just found that just to be just incredibly, you know, unfair and wrong. And I still keep that, you know, my the work that I do as a nurse is in regulatory, and I have done work and I've listened, or I've reviewed charts. And so I know where the system is broken. So the fact that it was my son made it all the more upsetting. And then every morning I would wonder, you know, why am I living? You know, I shouldn't have had to bury my son. As a mother, you know, no one wants to bury a child. So I had those feelings. I don't think, you know, I don't think I had feelings of suicide, but I had to question my own life and my mortality in the context of Scott's death. So in order to move towards acceptance in the beginning, I told my story. And thankfully, there were places that I told my story over and over and over again. And I learned where to tell my story in a safe context. I began to be able to hear the word death and the word suicide in relationship to Scott. I saw Dr. Arbore. He was one of my first grief counselors that I worked with. And he didn't start my first meeting with him saying, and Scott died, and he died by suicide, but it certainly was early. And I know that he's experienced, and even though it made me cringe and it took my breath away and my heart would stop every time I heard it in the beginning, I recognized that that was part of the reality of the suicide, and I had to hear this. And then eventually I could say it. I learned to ask for help, but I learned to seek help in a place where it was safe to seek help. So I learned quickly that family and friends may not necessarily be the right people to go to for support. I recognize that they too, those of us who were intimately, well, it's comforting when you have a you have a functional family to be able to use each other as support. If you have a dysfunctional family, which mine is, it wasn't a good place to seek support. But I had to learn that painfully. And sometimes, you know, different groups, even a 12-step group or a certain therapist or a counselor may not be the appropriate place. I've heard people talk about not being heard in sessions. So thankfully, I was, you know, I sought and I was paired up with people who had experience in suicide. I had to learn early not to act out of feelings of anger and grief inappropriately. And I learned to monitor myself, that when I would feel this incredible rage and out of controlness, I needed to pay attention and not yell at the Nordstrom clerk because of my own grief. And I also had to learn that life doesn't stop for me, even though I'm grieving and I went through this horrible experience. And part of my work was defining the relationship. So I had to look at the truth. You know, who was Scott? I gave birth to him. I was there, you know, when he died. But all I could think of was defining Scott in terms of the suicide. You know, what were we together? I was quickly reminded that he would no longer be visiting me, and things as simple as changing a light bulb was upsetting to me because those were things he did for me, and I could no longer depend on him in that way. And in terms of our relationship at the end, it was, you know, challenging because he sought to me for support, especially in terms of money and food and that. But unfortunately, our last contact was he stole my iPad. And this was a series, as addictive behavior often is, of a lot of that. It was more of it. But at this point, I was really concerned about him. And I said to him, I wrote him a loving text and said, I'm really worried about you. Please seek help. And, you know, would you please return my iPad? Because I can't do this anymore for you. And so that happened the Wednesday before he took his life. And I chose not to reach out to him on that Sunday. It was Easter Sunday, and then he took his life on Wednesday. So I had to deal with that, you know, that even though if I had not said what I said, and I did reach out to him on Sunday, it still might not have prevented him from taking his life. So I accepted that there probably wasn't anything I could have done to prevent it from happening. And so I didn't have to feel that responsibility anymore. So in terms of redefining the relationship, moving from the acute pain, I was able to, as time goes on, you know, I remember the day that I laughed for the first time, and I didn't feel guilty when I wanted to do something other than cry and mourn. It becomes okay. And it didn't mean that I was losing my connection to Scott, because those feelings are very intense. And it feels like that connection is no longer there. But that's not what's happening. I recognize now with some perspective that my relationship was evolving into something other than this intense grief. And I became more accepting of the internal relationship. And when I say that, I mean it in the context of spiritual and internalized in my heart, that my relationship with him, that's where it dwells. In terms of ending suffering and getting out of my own way. So I recognized my feelings that were related to Scott's death were part of the grief process. When you come from a dysfunctional family where you have happy feelings and then you have angry feelings and you don't have any feelings in between, then grief, feelings of grief can be overwhelming, but that is the gift that I received out of working through my grief, is recognizing and embracing and feeling those feelings. And in doing that, you know, I could stop with the what ifs and the woulda, shoulda, couldas, because I could not have stopped this process from happening. I recognized my maladaptive behaviors. For me, it's obsessive eating and spending. And I'm not perfect, but I certainly don't do it the way that I did in the beginning. And I've learned as a participant and also as a facilitator not to judge or compare my grief with others. Resilience, I think, is something that we as grievers need to recognize that it lives within us. So the things that I do is self-care. Grief is a multi-dimensional experience. It's spiritual, it's physical, it's emotional, and mental health certainly is part of it. I've taken the strengths that I used in other difficult situations and applied them. So relying on my faith community, my family and friends that are empathetic listeners, using grief drop-in groups, support groups. I participated in an 8-week basic group and then went on to do more work in an advanced group. I've done writing through loss workshops, and I've learned to set boundaries. I learned how to say no when it was my 40th high school reunion. I told my best friend from high school I would not be attending. And she kept saying, oh, you're going to, you'll change your mind. And I said, no, I'm not. I don't want to go to a reunion and have to talk about, I lost my son to suicide and I don't have grandchildren when everyone is going to be talking about their children and their grandchildren. So, maybe at the 45th or the 50th, but, I don't have to make those decisions today. And I've redefined my life with and without Scott. So I recognize that birthdays, holidays, and death anniversaries are triggering. So I strategize how I'm going to do that. So I usually take time off if I think it might be difficult. I use rituals to recognize his death anniversary. I'm Filipina, so it's easy for me to do that because it's built into our culture. We recognize anniversaries either with a rosary novena, or in this case, it was a milestone, the 5-year. I did an event through the church, and so people attended that love me or love Scott. I've been open to experiences that serendipitously appear. And I'll just share with you shortly that things happen for a reason. So the transplant games I attended in 2018 was something that came out of the blue. And it was only because I attended a grief workshop around the holidays, and I brought Scott's donor card, which I had shown earlier. And it turned out that the facilitator daughter was a cystic fibrosis lung heart transplant, and she introduced me to the transplant games. And so I was invited to attend. And this is where internationally all these families of that have lost people to traumatic loss, that have made the decision for their loved ones to become donors, meet the recipients of organ transplant. And they meet in this incredible venue, and they actually say thank you for making that decision. And I'm talking about the recipients. It wasn't Scott's particular recipient, but it was a surrogate way of having people acknowledge Scott as a hero. And I would say that for me, this was tremendous. And I finally let go of my guilt in terms of his suicide, and that he really gave the gift of life to 3 people. So restoration, I am a different person. I recognize that. And so part of me is new. And so I have had the opportunity to work as a volunteer of giving back to the Institute of Aging and the grief community, because they were there for me. And I feel deeply committed to this, because it's through this that we heal, by hearing other stories and sharing our own. I co-facilitated survivors of suicide loss through Mission Hospice. I garden and meditate, and I learned to do that during the pandemic. And my new discovery as a writer, through writing through loss inspired me to become certified as an Amherst writer and artist workshop leader. So my goal is to begin a grief writing workshop. And then I continue to work. So I just got certified with the state of California as a master trainer. And I practice self-care and forgiveness. So how I would like to end is, if I can find my cursor, excuse me, because I have 3 screens open, is to say that grief never ends for those of us who have experienced a loss, and certainly with suicide. And I'm going to read you a piece that I wrote this past summer. And the prompt was, write an open letter to people who don't know how to support grieving people. Tell them what you need. To whom it may concern, despite the fact it has been 5 years since I lost my beloved Scott, time does not heal all wounds. This is a misconception, and if you would like to be a sympathetic friend, please understand the wound remains. It is not acute, therefore the pain is not severe, does not hurt as it did in the beginning, and I am no longer consumed by the pain, but it still aches. Like a fractured ankle, the new bone heals over the break, but I still feel pain during extreme cold or a stormy day, or when I step on it with great force. It is a reminder of that old break, that I am still vulnerable. So it is with grief, unpredictably predictable, especially on Scott's birthday, holidays, and most importantly, on the anniversary of his death. But like the weather, I may be caught without an umbrella in the storm of a Beatles song, the sight of a sushi restaurant I used to frequent with him, watching a Giants game, or baking one of his favorite desserts like a lemon bar, which may send me into an unexpected tailspin of grief. It doesn't mean I am depressed or pathologically obsessed with my grief. This is the expected ebb and flow in the cycle of grief. And about those labels like normal grief, please do not place labels on my grief or judge me. Nothing about losing a child is normal. Therefore, I no longer consider myself normal or abnormal. I am simply a mother who has lost my son to suicide. There is no expiration date for grief. I no longer have expectations for family and friends. I simply love you for who you are, and I no longer feel this need to hoard our relationships. And if needed for my protection, I apply the Marie Kondo method of saying thank you and goodbye to relationships that fill me with regret. Instead, I am filled with gratitude for my most cherished friends who have been constant companions throughout my life. Some longtime friends were there at the beginning, but fell out after a month, and some by attrition as the first-year anniversary approached as time marched on. Some unexpected friends supported me in the beginning, but they too faded away into the rhythm of their own lives. Some simply could not deal with Scott's suicide at all and said nothing. It's okay to say, I'm sorry for your loss. I don't know what to say. One of the most poignant and honest communication came from a friend who I've known since 1987. She simply emailed, I cannot deal with Scott's suicide. I'm sorry. While I miss her, I forgave her instantly because she told me her truth. Please forgive me. I've never heard from her again despite my outreach to her. The surprise and gift of my losing Scott were the allies who stepped up and joined me and poured out their love from the beginning and continue to ask, how are you? And are willing to listen if I say, I'm having a bad day. As I continue on this journey, I have also gained the fortification of fellow grief travelers who share their feelings with me, a myriad of honesty that ranges from sorrow, rage, sadness, and yes, even joy when they speak of their loved ones. They have modeled and given me permission to explore and help me find words for my grief. And those of you who have lost loved ones know having an empathetic ear to listen as we share during those most vulnerable moments is the place where healing occurs. Tears are welcome and are the expression of physical pain and emotions during times when words are at a loss. You don't need to fix me, but I always appreciate a tissue. I invite you to contemplate on what type of a companion you would like to be, because I promise you there will be a time when someone you love most dearly will die and it will take your breath away. It is inevitable in the cycle of life. We first have to be a companion before we can recognize what type of companion we need in grief. We do not get to choose the how and the when. But if you spend time now and explore your own mortality, or whether death is the taboo subject out of your fear, and learn how to define grief, you will not find yourself with a Pandora's box of overwhelming and unexpected troubles, but instead find a treasure chest full of an expression of your true humanity and strength you did not know you possess. Grief is simply the expression of deep and abiding love after someone dear to you is no longer physically present. And grief is unique to each of us, as relationships often are. I wish you a love-filled journey. Thank you.
Thank you, Mary, very much for your courage and your wisdom, of which you have a great deal of wisdom about this experience. And I'm just very grateful that you were willing to share that with us today. And I've heard your story before, and each time I learned something else really about life as a result of you speaking about Scott's death. So thank you very much.
Thank you, Patrick.
And let's see. So while we're, processing what you have shared with us, Mary, and it just reminds me again that many of you on this Zoom meeting today may have also had a loss of a loved one to suicide, a family member, a friend, a classmate, a coworker, an aging parent, a son, a daughter, and we just want to share our empathy with each of you. And I appreciate Mary saying the kinds of things that helped her, as simple as, I don't know what to say, can be very profound. And also, as Mary had acknowledged earlier, for any of you that have been, very depressed or very anxious, and I think especially during this pandemic, many of us have been really struggling with how we cope with, just daily life, and to have losses to suicide death or homicide death or death in general is devastating and changes us. And Mary, I thank you for doing such a good job of talking about how Scott's death has changed you. And I really appreciate that very much. So we're going to, keeping in mind that what we would really ideally like to do is to be able to reduce the number of deaths by suicide that occur in this country. And how we're going to do that is to keep in mind Scott and others that we have lost to death by suicide, and try to think of how we might be able to change that, because, I believe for over 40 decades that we can do something. And so that's what we're going to be talking about as we go through the rest of this program. And as Catlin talked about earlier, in 1973, the Friendship Line was created in an effort to try to find a way to support older adults and younger disabled individuals who may be contemplating suicide. And what I believe then and believe, to this day, is that if we could decrease feelings of loneliness, if we could decrease feelings of isolation, a feeling of, not belonging, a feeling that I am all alone in the world, that I believed at the time that, and I still do, that we can impact the intensity of suicidal thinking by letting someone know we care about them. And since 1973, we've been combating loneliness and social isolation through creating meaningful conversations with people who call us or that we outreach to. And Friendship Line volunteers, and I'm sure there are many of you on this training today, and I just want to thank you. And also all of the volunteers and staff at the various crisis lines, hotlines, or warm lines in your communities across the country, for the work that you do. And we know our Friendship Line volunteers and our grief volunteers are skilled in the use of empathy and also in connecting. I believe then and believe again more strongly today that connections with others bind us to life. And I think that is the message that I hear from Mary, which is stay involved, stay connected. And that's what we try to do both through our Friendship Line as well as through our grief services. And as Mary said, she has been a facilitator with us and with other organizations as well to support people who are grieving, a variety of losses that are really hard to manage. And so our grief services are available for people throughout the country. They're on Zoom. And all you have to do is let me know if you know someone who would like to participate. Some of this information, as Catlin knows, and Mary does too, that, I'm also a teacher. And so I like to give people a lot of information. We're not going to go through these in any kind of detail, but, I want you to have them, and Catlin will be sending these out to you. But I'm just aware in terms of the number of deaths from 2015 to 2020, and you see that death by suicide is like number 15. And so I think that we sometimes look at this data and we think, oh, suicide deaths are decreasing. And I tend to agree with Dr. Ordog from the County of Los Angeles Department of Health Services when he writes, death certificates may not tell the entire story. I was surprised by the suicide rate reported to have a major decrease in 2020. It seems from most other reports that the suicide rate has increased since the pandemic began. This may be explained by the fact that the category of unintentional injury had a major increase at the same time, and the fact that this category includes drug overdoses. As there is often inadequate history in a fatal drug overdose case, many of these may be purposeful and so suicidal. This would explain the perceived increase in suicide rates since the current pandemic began. Perhaps further analysis of the data would elucidate this incongruity. And we need to just be, thoughtful about that, and not lose sight of the work that we need to do with people right now today who are depressed, thinking about death and or suicide as a means to escape from, unbelievable pain psychologically and or physically. And in this slide, we're just looking at suicide rates in America across age groups. And you can see that the 45 to 54-year-old, group is quite high, and then those over the age of 85 as well. And by 2038, the number of older households aged 85 and over is projected to reach 10.1 million. And what we see, for those of you who work with older adults or families that have older adults, the increase in loneliness and social isolation, depression, anxiety. Here on the Friendship Line, we talk to thousands of people who live alone or live with others and are in their 70 to 80 age corridor or the 80 to 90 age corridor, and they are suffering even though there are people there. But again, ageism, racism, sexism, homophobia, transphobia, are all factors that can reduce a person who is in one of these marginalized groups to have a feeling of despair and to feel disconnected. According to the American Foundation for Suicide Prevention, there's no single cause for suicide. As Mary was talking about Scott, I was thinking about that there are reasons, why Scott turned to drugs. There were, something in his environment, his friendship network or whatever, that, he was having trouble managing. And just as, use of alcohol is a warning sign of problems, so is the use of opiates, and other factors. Suicide most often occurs when stressors and health issues converge to create an experience of hopelessness and despair. Depression is the most common condition associated with suicide, but it's often undiagnosed and often untreated. And then I think we all are very familiar with the concept of stigma and how there's a stigma on mental health. And we've been hearing that now from athletes in various sports where they're coming out and, and talking about the problems that they're having with their own mental health due to the pressures of being a celebrity, sports, person. And so we need to be very thoughtful about that. I know many times back in the early 70s, when I would say on the Friendship Line to people, older people or younger people, I would say, well, you're really describing some of the, the symptoms of depression. And they would say to me very quickly, what do you mean? Do you think I'm crazy? And here we are in 2021. And just the other day, I was talking to someone in their 60s, and I said, oh, you're really describing some of the symptoms of depression. And he said, what do you think? I'm crazy? I wonder how much progress we have made at reducing stigma when it comes to mental health. And that stigma is also associated with people who die by suicide. And as Mary very eloquently was talking about, is that also the stigma of people who've lost loved ones to suicide. some of the warning signs, and again, I'm not going to go into detail with these, but to mention some of them, certainly access to lethal means, including firearms and drugs, are a environmental and historical factor. Prolonged stress, being harassed by people or bullying, and keep in mind that senior bullying, and I'm not talking about seniors in high school, occurs, and some of you are very familiar with that. And my work has given me the opportunity to meet with people in assisted livings and, nursing homes, who are older and who will let me know how terrified they are, or that they want to kill themselves as a result of being bullied in those institutions. Again, stressful life events, divorce, rejection, financial crisis, and other transitions or losses, can really, dim our spirit, where we just can't manage that. And then, of course, disconnectedness, again, family discord, social isolation, loneliness, bereavement are all factors that contribute to people thinking about suicide, thinking about death. Other behaviors we mentioned, alcohol, drugs, people looking for a way to end their lives, looking for ways to harm themselves online, again, withdrawing, isolating, sleeping too much or too little, reaching out to people and saying really goodbye to them. Many times with our grievers, and I'm sure Mary has heard this too when she facilitates grief groups, is that people will say, now in retrospect, I think my husband, I think my son, my daughter, my friend, my parent was really saying goodbye, but I just didn't recognize it. And see, this is the part of this talk that I am most interested in, is increasing our awareness to be more aware, more conscious of what people say and do who are important to us. And what that means is we need to pay more attention. And I firmly believe that people who are, depressed, who are anxious, who are, struggling, with their emotions, they really benefit when we give them attention. But that doesn't mean we tell them what to do or fight with them. What we do is listen, just allow them space to say what's going on with them without interrupting them. Just listen, and listen with compassion, and listen with the idea that I just want to understand what my loved one, my neighbor, my friend is telling me. I want to, really emphasize sleep behavior. We are seeing, certainly with this pandemic, and I see this with the clients that I speak to on a daily basis, that they're having trouble with sleep, my older clients. And then I'm going to be 74 this year. And what I realize is that, I've rarely ever had nightmares, but since this pandemic began, I have these nightmares. I have disrupted sleep, and I'm very conscious of that. That that it's really, I think, appropriate to disclose to people with whom you work that if you're having a hard time, I think it's okay to let them know that. And I find with my older clients that they'll say, "Oh, I'm so glad you're telling me that, because I think I'm the only person that has that problem." And I said, I think many people have this problem. What we have to do is find a way to share that with others. Look at our behaviors as we prepare for the night. What are the steps that we take? If we're watching, the news on the TV, which, as you know, is not exactly pleasant, we may want to do that in the morning rather than the evening. And anyway, I just encourage us all to be very mindful when someone says to you, "I'm just having difficulty sleeping through the night, and I'm my sleep is disrupted, or I'm having nightmares and that sort of thing, would be important to do. And then other warning signs, include exposure to another person's suicide death, previous suicide attempts, family history of suicide, childhood abuse, neglect, or trauma. And I really want to emphasize, that the lasting impact of childhood trauma can really flare up later in life, in our 50s or 60s or 70s. And I just think it's really important that we acknowledge that if I had trauma as a child, it might go underground for many decades because we're busy with careers or life or family. But it might surface in our older years. Again, physical health conditions can be a warning sign, especially pain that doesn't seem to be managed, or pain that a primary care physician is saying to you, I think it's psychosomatic. I don't think you really are experiencing physical pain. Traumatic brain injuries, cognitive impairment, and or dementia. We also want to recognize our own reluctance to engage in discussions about suicidal ideation, suicidal thinking. And again, as I said earlier, we might fail to see the signs that someone is really thinking about suicide, or that we deny the meaning of these signs because we just can't believe, and I'm sure many of you have heard this or have said this, I can't believe that this individual that I love or care about would even consider taking their own lives, and that again is the stigma that people who are thinking about suicide, they don't want to talk about it because it's going to upset us, and we need to, again, to be more vigilant about that and be able to talk about what's going on with this individual, and and think about resources in your communities. As Catlin was calling out the states and the cities that many of you are from, and I know some of you are from Iowa and work on the crisis line there. You know a lot about community resources, but it's not good enough that we who work in these organizations have access to that knowledge. We really want to share that with the community. Our failure to respond effectively by the suicidal individual may be seen as proof that we don't really care about this person. So we need to connect, even though I know that that can be difficult. And talking about suicide is hard, and our difficulty to talk about one of the leading causes of death in this country is no accident. Again, as I was saying, and many of you already know this, and I'm just really validating you, it's a direct result of taboo, stigma, fear, and ignorance, And so, as we go through, this next half hour, I just want to, just imagine that you are contemplating suicide as a result of, these stressors. And how would you begin to communicate with someone about their feelings of despair? How would you address, someone who was really thinking about suicide? And I think Mary offered some tips to that. And so let's look a little deeper at stigma. According to some researchers, stigma has been shown to increase suicide risk, as I implied in that last slide. Personal stigma towards suicidal people may reduce engagement with professional services and lead to more negative attitudes. Low suicide literacy, limited public knowledge about suicide has also been shown to impact outcomes for people experiencing suicidal thoughts or behaviors. We also know there is a lot of secrecy about suicide loss, and mental health outcomes. Devaluation of those who died by suicide or attempted suicide and their families can be traced back to the Middle Ages, when they would be punished by law or punished through their religious beliefs. Today's suicide stigma results when suicide is associated with stereotypes that trigger prejudice and discrimination towards people affected by suicide. Who hasn't heard that phrase, which is, oh, your loved one died by suicide? Well, aren't they being selfish? Look how selfish they are. Wow. It's like my loved one died by suicide death, and somebody who I thought was a friend, a coworker, is saying, oh my gosh, they were so selfish. And you can hear the discrimination. You can hear the stigma in that. Suicide stigma not only affects people who experience suicidality, but also people who grieve their death. Suicide loss survivors, as Mary was talking about, are at increased risk for complicated grief. Suicide, death, is often sudden and traumatic. And also, we know people who have lost loved ones to death by suicide, but they call it something else. They don't want to talk about it. So they'll say, oh, my loved one, died as a result of an accident or, something like that, because they don't want people to criticize them. Discrimination may be direct. People who have attempted suicide are subject to social distancing, as are those directed at ethnic or other minority groups. People with direct personal experience of depression or suicide strongly experiencing stigmatizing, affect that is sometimes internalized by themselves. Perceived stigma is one of the main factors associated with the risk of suicide among those experiencing mental health concerns. Suicide can be seen as an escape from the stigma itself. When people who are depressed or anxious or, dealing with other mental health concerns, they want to communicate, but they don't want to be devalued. And so they fear, talking about it because they fear someone's going to put them down or say, you don't feel that bad. It's just a divorce, you're going to be okay. We tend to tell people what we want them to do without inviting them to share with us what's happening with them. Disparities in mental health service use by racial, ethnic minority groups are also well documented. In combination with the findings that racial, ethnic minorities tend to receive less overall mental health care, less outpatient mental health care, and are less likely to visit mental health specialists, suggests that older racial, ethnic minority adults may not be receiving needed mental health services. Rates of treatment initiation and adequacy indicate that the majority of older adults, regardless of race, ethnicity, are not receiving needed mental health care. And again, I'll just draw your attention to ageism. What we know in this culture, this society, is the worst thing that you can possibly be is to be old, and then it's even worse, as one African American woman had said to me, and she was older, she was Black, she was poor, and she was sick, and she was in the very low socioeconomic bracket. And she said, Patrick, I'm a footnote in a footnote in a footnote. Basically, I don't really even exist. And if that doesn't spell loneliness, I don't know what does. Unfortunately, most suicide intervention and prevention programs are based upon known risk factors for Caucasians due to their higher rate of suicide in the past. However, researchers are now beginning to investigate potential risk factors that may be unique to other ethnic groups. And that's why I was very happy that Mary was willing to, share her story of, of her son. just to indicate that, wait a minute, not everybody that dies by suicide is white, and we're seeing, more increases in other ethnic groups in terms of depression, other mental health issues, and also suicidal ideation. Research has also found an association between sexual orientation and suicidality. Suicidal thoughts and attempts are higher among gay and bisexual males than their heterosexual counterparts, especially during adolescence. This slide, just discusses who uses mental health services, and we see there that that racial and ethnic minorities are less likely than white European Americans to use mental health services. Now, this isn't a news flash. We've known this for a very long time. What the problem is, from my perspective, is, are we doing enough, to recruit, people from, these ethnic or racial groups to, work in mental health? And I'm sure that many of you on this Zoom meeting do work in mental health. And, and I think that is, we just need to encourage that more and more, and find ways to engage the community in reducing the stigma of mental health and opening these doors to mental health, for people from other backgrounds. Some of the research, for example, African Americans are 21% less likely, as you saw on that screen, to use mental health services. Hispanics and Latinos are 25% less likely. It's not just a matter of socioeconomic status. People have long assumed that differences in income and health insurance access account for disparities, but data are showing that race is an equally independent predictor of mental health utilization. The problem of underutilization is especially severe for Asian Americans, who are 51% less likely to take advantage of mental health services than their white European American counterparts. So again, I just think we have to, work together, so that everyone in our communities, whether we live in rural communities in Minnesota or Michigan or Pennsylvania, that we really need to support our, our fellow, community members, to know that they are welcome at this table, and that we can all work together to provide help and support. The research also points to the need for greater specificity in analyzing disparities. If we're setting up services for African Americans, according to researcher Trimble, who are we talking about? African Americans from Haiti, from Boston, from Guatemala. I mean, how are we looking at this? There has to be more precision in how these labels are used in the context of unscrambling the deep meaning of culture and tailoring programs in ways that really reflect the deep cultural meaning of who a person is. And this isn't just relegated to race, it's also to sexual orientation. That, someone who is transgender, who is, 70, may be very different from, a lesbian or a gay man who are in their 30s or 40s or 50s, or very different than the needs of bisexual older people. We just have to recognize that people are very, very, very unique, and one size does not fit all needs. And I've heard people say to me, well, Patrick, if we were, catering to everybody's needs, it would cost a lot of money and would have to do a lot of training. And I say, okay, let's do it. Let's begin the process. People, need to be cared about, So what are some of the interventions, that are, through evidence-based training. Well, the training, training primary care doctors and nurses to better screen and treat depression with supplemental help available from psychiatrists lowered suicide rates in many studies and non-fatal suicide attempts and suicidal ideation. Because one thing that we know about older people is that, sometimes very reluctantly, but they do see their primary care physician. And of course, now many of those visits are on Zoom, and how many older people are able to use the Zoom platform to connect with their doctor. And when the doctor says, use your cell phone to take a picture of your foot because you're saying that your foot has swollen up. I mean, I don't know about you, but I'm not the greatest when it comes to technology, as Mary and Catlin will certainly testify. So it's hard, I can do it, but boy, it's not an easy thing. And I think of some of my older clients, it's like, oh my gosh, I say the word computer to them and they just freak out. We really need to do something about this. Mental health education in adolescents resulted in less suicidal behavior, whereas studies targeting teachers did not find benefit. So again, we have to look at, what's happening in our schools, what's happening in our communities, what's happening in our, our nursing homes, and how are staff trained, to recognize, the warning signs of suicidal thinking. There have been no controlled trials targeting gatekeeper education in adults, and so we need some data. We need to look at the evidence. Depression management education of doctors has been shown, again, to lower adult suicide rates, but it's not mandated. And we need to kind of, again, really investigate, the role of education with a lot of us who work with older people as well as younger people. Screening for suicide risk to identify otherwise undetected at-risk individuals, if coupled with effective referral for evaluation and treatment, was found to prevent suicidal behavior in some studies. And again, my master's degree was in psychological research, and so I'm always on the hunt, for evidence-based studies that give us some insight into what seems to be more effective when it comes to preventing suicidal behavior. Other treatment interventions include medication. Antidepressants reduced suicidal ideation in some studies. An FDA meta-analysis found that antidepressants lowered risk of suicidal behavior in older age groups, but subsequent pharmacological studies found that selective SSRIs reduce suicidal behavior more broadly, including young adults. So again, researchers are trying to be more specific when it comes to, medications, and not to think that because my loved one is on an antidepressant that, they won't die by suicide. And I know many of you know this, that, people who have been seen by a psychiatrist or seeing a psychiatrist or have just been to their primary care physician, there are studies that show that that older person who had seen that primary care physician a week ago died by suicide, but the doctor didn't realize that the person was thinking or at risk. So we need to, again, what do we have to do? And I really think it has so much to do with awareness. That's one of the things that I think Mary was so, able to do with us is, let's raise our awareness through Mary's story, so that, another person in their young adulthood won't have to die. It's a matter really of life and death. So CBT, psychotherapy, we know decreases suicidal behavior risk in adults and adolescents with depression and in adults with borderline personality disorders. CBT for suicidal individuals is designed to help high-risk individuals apply more effective coping in the context of stressors and problems that trigger suicidal behaviors. We also know through studies that CBT, cognitive behavioral therapy for those who have substance use disorders, have reported that there's a reduction in suicide attempt frequency. Some of you are very familiar with dialectical behavior therapy, as Catlin said earlier, that we know, and we're very happy to have, therapists who are joining us, nurses, as Mary is one, psychologists, social workers, social service providers. So some of you are quite familiar with this, but I also want to say that those of you who are just in the community, living your lives, I really am grateful that you're here, because we got to, I like the grassroots approach that you might say to somebody. I went on this Zoom meeting and I heard a woman talk about the death of her son by suicide and what she had gone through and what he went through. And, so I'm when you receive the PowerPoint slides from Catlin, you certainly can share them with other people. I don't care at all about that. Group psychotherapy, I had anticipated that with group psychotherapy that there would be a more positive connection with a reduction in suicides. But none of the studies of group psychotherapies that were done in this very recent, and I have a reference list attached here, reported reductions in non-fatal suicide attempts, although some studies of membership of group psychotherapy did show reduction in suicidal thinking. Contact or active outreach following a suicide. And I'm just watching the time here because I want to have some time for questions, so I'll try to wrap this up quickly. Because the greatest risk of suicidal behavior is after discharge from the emergency room or from an inpatient hospital stay. And listen to this, 80% of suicide deaths happen within 1 year after discharge from ERs or hospitals, inpatient. Follow-up interventions as simple as sending postcards to that individual who was, released from the ER or hospital stay, have prevented suicide attempts based upon, some studies. Psychoeducation paired with telephone or in-person contact reduced the suicide rate over 18 months among people who were attempting suicide. And, for those of you who work on telephone lines, and, again, my passion has been friendship line, telephone contact, and, I really, really believe that connecting with people, acknowledging people, having even a short, meaningful conversation can support people who are maybe thinking about death and or suicide, but are hesitant to share for reasons we mentioned earlier that has to do with discrimination and stigma. Internet-based interventions have not been shown to prevent suicidal behavior, but they're highly scalable. And so, researchers are, I'm sure, looking at that right now because so many people, and many people in the 70 to 80 corridor and even beyond have skills that they know how to use a laptop and or a smartphone and that sort of thing. A game-like mobile app showed promise in reducing self-injury and suicide plans, but not suicidal ideation. And that was a pilot study, so we don't know what that really is going to do. We have evidence showing the positive impact of crisis lines, training of healthcare professionals, and maintain contact with the people experiencing thoughts of suicide have thoughts of suicide have on decreasing suicide rates. So, crisis lines, those of you who volunteer or staff or have ever called crisis lines, I just support you so much because, we know that they do make a difference. By putting space and time between someone experiencing thoughts of suicide and their method, namely firearms, we greatly increase their chances of survival. We see very promising research surrounding firearm safety legislation and its potential to reduce suicide rates at population levels. So quickly, what we can do is just connect with people, call them up. Connections are paramount to caring for people who are lonely. Be as present as possible with people who are depressed. Offer the gift of attention. And that doesn't mean you have to, talk at them. What you want to do is say, please talk to me and I will listen. Empathize with people's losses and suffering. And, again, I just want to say ageism is something that we've got to contend with, as well as racism and homophobia and sexism and transphobia, etc. And so it just in conclusion, preliminary data in a report to the Journal of the American Medical Association shows that while there was a 17.7 increase in overall deaths in the US, there were fewer suicides than those reported. Due to the number of COVID-19 related deaths, suicide dropped to the 11th leading cause of death. But as I said in the beginning, there are a lot of questions about how we determine the number of deaths by suicide. And we want to think about this. And although this is promising, we hope that this is signaling a trend in lowered suicide deaths in the country and an indication that the efforts of suicide prevention initiatives are effective in lowering suicide rates. And the last slide is too often we underestimate the power of a touch, a smile, a listening ear, an honest compliment, or the smallest act of caring, all of which have the potential to turn a life around. And some of you are probably familiar with Leo Buscaglia, and that was a statement that he made. Catlin, I'm gonna get out of that.
Yes, I have some questions here, and I can pose these to both of you. And
Sure.
I collapsed a couple of the questions because we had multiple parties asking similar questions. And the first question that came up a few times was this: how do we support someone who is taking medication for depression and seeing a counselor, but continues to be depressed and is still contemplating suicide?
Mary, why don't you go first?
Mary, I think you're muted.
Patrick.
Okay, I'll go first. Oh, good. Are you unmuted now, Mary?
I don't know.
No, I can't hear you.
You can't hear me? Okay.
Well, we can hear you very slightly, Mary.
Really?
Yeah.
Oh, I know. Okay.
Oh,
It
there
would
you are.
help if I put my headset down. One of the things that I've noticed in doing a chart review is people who are on chronic SSRIs. And so I would, just the nurse in me would want to know how long were they on it, and, who's oversighting them. Because if they don't have supportive therapy and someone who is doing an adequate assessment, then maybe they need a change. But, I will leave the therapy piece to Patrick. So go ahead.
I appreciate what you were saying, Mary. And what I think it's really important that we just don't put all our eggs in one basket. And I think all of you that do therapy, many times I counsel people who are doing therapy with somebody who is ideating suicide. And what they often say to me is that they really just never thought that they would be seeing somebody that's actively thinking about suicide. And it's tough. And I don't think that we do enough training in our social work programs, or in California, the MFT program for psychologists, or others. I think there needs to be more education, but not necessarily around the, let's say, cognitive behavioral therapy that the person is using. I think it's about utilizing community resources so that the person can connect with a grief group, for example, as Mary and I know so well, or a writing workshop about grief. Again, Mary had talked about. I think that I think we forget that people live in a context. They don't live in the therapist's office. And I think it is helpful to be more aware of those other 6 days when the person isn't seeing the therapist, that we want to encourage people to connect, to join, a club or something. We have one of our grievers has started a group to read the book by Francis Weller on grief, and and he has like 10 people in there. I think people are hungering to connect, and especially people who are depressed, they tend to withdraw. But I think if that therapist says, let's look at resources in your community that you might want to join, and then we can talk about that each week you come to see me. How is that going? So anyway, that's a long-winded version of connection. Just connect. Catlin?
Yes, Patrick, can you hear me?
Yes.
Okay, so, and this is for Mary too. One person has written, I survived my own attempt 4 years ago, but I feel that my family is still in that place of worry. How can I help them move on?
I think if it were someone that I loved, I certainly would be worried, and yet I recognize that it's I guess the actions of the person is what matters the most in terms of their intent, that they're over, that they feel they're getting the support and they have done the following things. And it's up to you if you want to share, how much you want to share. But I don't know if it were me and you were my child that I would ever stop worrying. So that's just a realistic appraisal as a mom and a nurse and a caretaker. So I will leave it up to Patrick in terms of what you would want to say.
I don't know if I can illuminate that any further. I was just thinking with that question that as a adolescent and a young man, I attempted suicide 4 times over a 6-year period. And my parents, my brothers, were the last people that I ever wanted to know that information. Because talk about stigma and prejudice, it would not be safe, for me to even ever, let that information out. And I highly doubt that my 3 brothers would ever in a million years join a Zoom meeting like this. So I don't worry about them finding out, because they are very illiterate when it comes to mental health. So I think that if the person feels a lack of trust, I don't necessarily think that we should have that discussion with them. However, I would urge that maybe you and your family might want to have a family therapy session with a social worker, and or a psychologist or someone, to really tackle this in a safe environment, rather than the kitchen table with ma and pa. Would be my comment. Catlin?
Yes, I think we have time for one more question, but I also want to say to everybody listening, I will collect the questions not answered during this time and send them to Patrick and Mary, and we'll get those answered and put them in the packet of information that we'll be sending, which will also include some suicide prevention training information, including up-to-date empirically studied information and the Francis Weller books that Patrick gave to us.
I just thought of the name of it, The Wild Edge of Sorrow.
Okay, we'll put that in the email.
You have to forgive my delay in my information transfer there. I just totally forgot.
I wanted to, okay, so I think we should end with this one, because as one person says, truly grief never ends, no matter how the death occurred. So what words were comforting? This is for both of you, if any, from friends or family. What words may have helped you cope?
Well, I'll go first, Mary, and then you can go second. With my own losses, I think what we have to do as grievers is to lower our expectations. We've got to remember that we are living in a grief-denying, death-denying society. And the message that I'm sure many of you have heard over the decades is, well, aren't you over that death yet? Hey, don't talk about that death. It's too depressing. Let's have a beer, or 10. Let's just be happy. And I think we have to recognize the stigma around death, the stigma about grief, that people don't quite understand it. And that's why, again, Mary, I was so grateful that you were sharing that, that grief doesn't have an expiration date. We're going to grieve our whole lives. We can't erase mom out of our history, or our son, or our daughter, or our sibling, or whoever it might be, a friend or a loved one. They're still with us, and what I encourage people to do, as Mary had suggested, if you want to say something, say, sometimes I don't know what to say, but I'm willing to sit here while you take a shower. I'm willing to sit here when you need to, do some cooking for your kids. I'll be with you. I'll help you. I'll drive you to the supermarket. What it means is, I'm not afraid of your grief. You don't have to hide it. And that's what I think we have to do. If we know of someone, a friend, a loved one, a coworker, say, if you want to talk, I'm willing to listen. I'm willing to listen. So as a support of a griever, you should talk less and listen more. Mary.
I was just going to say, I can't think of anything specific, but again, the idea that someone would say to me, I thought of you today. I'm wondering how you're doing. Is there anything I can do for you? Because then that gives the person a choice to say, oh, I'm doing okay today, but, check in with me in a week, because maybe I might need something. Or if you say something specific, like, is there something I can do for you? Do you need, like a friend of mine said, what can I do for you? And I said, I don't have any more tea. Okay, fine. I'll go to the store and get you some tea. That was very specific. And I still remember that to this day. And it's been 5 years. But my dear friend who knows I love green tea. And I said, I need herbal tea because I don't want to stay up at night. I mean, that was just really thoughtful and it was concrete. And as Patrick says, it's your presence that means more than the words. So that is the biggest gift for any of us who have lost someone.
Mary, Pat, thank you so much for this training today. And thanks to all of you who've participated. It was true participation. The chat notes were very amazing, sharing of information, and we will be getting a packet of resources, etc., out to you within this next week. Thank you for being here. And Patrick, if you want to stop the recording now, that would be wonderful. Thank you.
I will. Thank you, Catlin. And thank you, Catlin, for your, managing this whole training today, and Mary for giving up your time and sharing your story. I really, really respect and admire that. Thank you both.
Absolutely.